Bismillah ar-Rahman ar-Rahim. It gives me a great pleasure and honor to be here. I would like to thank Professor Ayman for inviting me to talk about an overview of Duchenne muscular dystrophy. So as this is an overview, means I'm going to cover many parts, but very quickly and very briefly. So Duchenne muscular dystrophy is not a new disease to many of you. It is a rare disease by definition because the incidence is about 1 to 3,500 to 5,000, depending on where you live. And it is due to a genetic mutation in XP21. So it's X-linked recessive disorder. In about 2/3 of the cases, the problem is the transmission from the mother, but in about 1/3 of cases, it is actually a de novo mutation. So disease progresses. It is a progressive disease, and it progresses over 2 to 3 decades, leading to early mortality, mainly due to cardiopulmonary failure. This is just a nice study which was done, very basic, looking at spectrum of neuromuscular diseases encountered in a pediatric clinic. And you can see by far Duchenne muscular dystrophy is the most common one, followed by spinal muscular atrophy. And this is just the histology of some anatomy about the muscles. As you can see here, this is what a normal muscle should look like. This is a muscle of a child with Duchenne muscular dystrophy. You can see the myofibrils are really fragmented, they are far away from each other. You get a lot of connective tissue disease in between, as well as inflammatory cells. And you can see, obviously, there is different sizes, which indicates muscle degeneration. So dystrophin is probably the largest, if not, gene in the human body. It's a cytoplasmic protein that connects the actin filaments to the cytoskeleton. And usually in patients with Duchenne muscular dystrophy, this end is the one that is affected. It's located in the X chromosome, and it has many roles, but the most important one is actually in muscle contraction, ion challenge regulation, as well as matrix composition and acellular stress response. So as many of you know, there is over 5,000 genetic mutations, mainly large deletions made almost over 2/3 of the cases. You can have duplication as well as nonsense mutation. Deletion are the most common type and concentrated, especially between exon 45 and 55. And that's why there is many of the medications that are used for the treatment trying to target those areas. So the clinical presentation, which is mainly what I get involved in my role in rehabilitation and neurodisability, is the disease stages. So we see these children sometime when they present early with motor delay. And children with Duchenne muscular dystrophy, like any child with developmental delay, they present sometimes to the general pediatrician, sometimes they can present to a neurologist, sometimes they can present to the rehabilitation. Sometimes we have seen patients presenting to orthopedics clinics because of toe walking. But you all know about the symptoms and signs of the disease, especially in the early ambulatory area: calf muscle hypertrophy, motor delay, speech and language delay sometimes can be the initial presentation. Symptoms that include mainly motor delay, including difficulty standing from sitting, difficulty with running and hopping, and difficulty with climbing stairs. And it's really interesting because those three kind of features are the one that we use in the assessment when we do the rehabilitation and for those children. Now, followed the early ambulatory stage, which happens in the first 7 years of life, the late ambulatory stage. And it's really important when you see those children in the clinic is to classify them where they're at. So the late ambulatory stage happens around 11 plus or minus 1 year. Increased loss of ambulation, and sometimes can be quite sudden. they start to sit on the wheelchair a bit more and more and more. And when you do that, you will find always there is a decline in their forced vital capacity and their cardiac function. So it's important when you see them in clinic in that late ambulatory stage to always make sure that they're being monitored by the cardiology and the pulmonology. Then when they become they lose their ability to kind of walk, they go into the early ambulatory stage and they become full-time wheelchair bound. Now, this is an issue now with the treatments which are currently available because with insurance, they want those children to be mainly here in these two areas. And we have 3 children on antisense oligonucleotides who we're struggling with getting insurance approval because they are now in the wheelchair state. And finally, in their late teens to 20s, they start to kind of go down really quickly with increased respiratory impairment, ventilatory support. They start to present to the emergency frequently with feeding and swallowing problems, with aspiration, and increased cardiac dysfunction and heart failure. So in addition to the motor aspect, many of these children, they also present with intellectual disability and with learning difficulties. And the evidence for that is basically the dystrophin gene is also represented in the brain cells. Language delay, especially when they're really quite young. Many of them, they can develop ADHD, anxiety, and in about 15% of them, they can have autism spectrum disorder. So it's also important in the protocol that you need to make sure that you involve the mental health team as early as possible with those children, as soon as they start to develop or to show signs of anxiety or ASD. So this is the laboratory investigations, and depending on where the child presents, now with general pediatricians becoming really, really good, many of them, they refer the child already with, very high CK, they already made the diagnosis. More and more, people are not doing EMGs anymore. People jump straight into the genetics, Duchenne muscular dystrophy, genetic deletion and duplication. You can do either neuromuscular panels, or you can do whole exome sequencing. And if you can get copy number variant as well, then that becomes really good. Muscle biopsy, I think still there is a role for muscle biopsy, but in very, very, very few patients. And as they are normal children, you want to make sure that the vitamin D level is okay, the fasting blood sugar, hemoglobin A1C, especially if they're on steroids, as well as checking their bone mineral density. Now in our clinic, those patients are being referred straight to the endocrinologist for monitoring of their steroids use. There's always mimics for all these neuromuscular disorders, and I don't need to go over this, but there is other dystrophinopathies, myopathies, glycogen storage disease, fatty acid oxidation, sarcoglycanopathies, and dysferlinopathies. And always you can have patients presenting with proximal muscle weakness. They look like Duchenne muscular dystrophy with positive Gower sign because they have systemic diseases. And this is a list of the professionals involved in the care of children with Duchenne muscular dystrophy. We start from the general practitioners, general pediatricians, all the way down to the school teacher, special need coordinators, physical educators, and physical therapists. So when you see a child with Duchenne muscular dystrophy, what we normally do is obviously you have to go through the medical history and investigation, genetic testing to confirm the diagnosis. And then in addition to that, I always ask about pain. These children, they can have a lot of pain, especially at night because they cannot move sometimes or turn over. They can have small, frequent falls. Toileting can be quite difficult, especially if there is upper limb involvement, feeding, and school, especially handwriting. And as I said earlier, their mental health. A physical exam, these are the things we fill in our form. Vital signs, tongue hypertrophy, cardiovascular chest. If they are steroid treated, you look for striae, acanthosis. We check for cataract regularly with the ophthalmologist. As you can see there, this is a Gower sign. It's not specific only for Duchenne muscular dystrophy. You can see it in any child with proximal myopathy, especially if the pelvic muscles are affected. We assess all range of movement. I do that with the physiotherapist with me in the clinic. We assess their gait, and in a couple of patients, we actually refer them for gait analysis because they also showed signs of upper motor neurons in their lower limbs. Check for scoliosis is very important. We do that annually as part of their treatment. We check for their hips because they can also develop painless dislocations. And these are the motor assessment that we do in clinics. Some of our colleagues in neurology, they don't have time to do this. We see patients for longer, so we do all of these tests when we see them. The most important one is the North Star ambulatory assessment. These are tests now insurance will ask about when you trying to put the child on any treatment. The 6 minutes walking test, the 10-meter walking, and climbing 4 stairs. These are simple tests, but they can give you excellent indication about the function of the child. In addition to that, we just do a normal neurological examination, muscle power, range of motion, spine and hips annually. And we always talk about equipments, whether it's wheelchair, ankle foot orthosis, hand splints, and so on. So the medical treatment, steroids, still not favorable by many parents. They don't like it. Ideally, you should start when the child is about 4 to 5, whether you like prednisolone or deflazacort. Each one has got advantage over the other. There is also a lot of regimes that people use. Some people use daily, some people use weekly, some people use on and off. We check their height and weight, refer to pulmonology for monitoring for their forced vital capacity. They're really supposed to get DEXA scans every 2 years. You find that only in some hospitals. And if there is really severe osteopenia, our endocrinologists, sometimes they can put them on oral bisphosphonates, but they need to be monitored closely. Always we check their vitamin D level and make sure that it's kind of normal. And these are the things you need to do if you want to start the child on steroids. If you do not have an endocrinologist to refer to, you need to make sure that these things are done before you start the child on medications. It's important, as I said earlier, these children are referred to cardiology and they're being monitored. In my clinic, I always stress to the parents not to miss their appointments with our cardiologist and the pulmonologist because they do the regular echoes, beta blockers and ACE inhibitors. You would aim for an ejection fraction over 45%. When they go to the pulmonologist, they make sure that they've got all their vaccines, including pneumococcal flu vaccine. Many of them, when they get to the stage needing respiratory support, they may have BiPAP, cough assist, suction, and you want to make sure that the parents are vaccinated against COVID. Nutrition is very important, and sometimes these children, they do not eat well. Sometimes they're overweight, so you need to make sure that the balance is right. In few patients, we had children with feeding and swallowing disorder due to muscle weakness. It's not very common, but they do not sometimes eat well, and they can develop gastroesophageal reflux and constipation. Renal adequate hydration is absolutely essential unless they get into pre-renal failure. So in rehabilitation, as I said, usually these children, they become weaker in their lower limbs more than their upper limbs. So preservation of their upper limb function is crucial for independence and for quality of life. It will be much better if they can wheel their own wheelchairs and somebody to do it for them. Cardiopulmonary rehabilitation, including non-invasive ventilation. They see our chest physiotherapy, deformity management with contractures, scoliosis. We work very closely with the orthopedics team. And if there is problems with learning, we refer them to kind of our educational psychologist and neuropsychologist for cognitive assessment. These are just the equipment they use at, many of them, wheelchairs, and wheelchairs we send to our therapist to do a wheelchair assessment. It is really wrong to put a child with Duchenne muscular dystrophy in the wrong wheelchair. It will just increase their deformities, their contractures, as well as their hip instability. Many of them, they may need a sleeping system because of their contractures, as well as night splints and knee and ankle orthosis. As you can see, this is a child with severe wasting, a lot of deformities, contractures in their upper and lower limbs, as well as severe scoliosis. That's the end result for those children if they have not been managed properly and had proper rehabilitation program. So this is a message for my talk. If you have a child with Duchenne muscular dystrophy, please refer them to the therapist early. They need referral for physio, occupational therapy, speech therapy, as well as orthotics and prosthetics. They need resting splints, which are needed for not for ambulation, something like that, resting splints. Gentle strengthening. We do not do strenuous exercise for children with Duchenne muscular dystrophy because that will increase the muscle breakage. So very gentle exercise, improving their endurance, oxygen, breathing. It is very important to keep them as independent as much as possible in their activity of daily living. Mobility aids, our occupational therapists, sometimes they can give them utensils, especially if they have foot deformities, and splinting of their hands and wrists. And these are the outcome measures that we use. Motor impairment, we measure the muscle strength, North Star, 6 minutes walk, 10-meter test, pulmonary function test, echocardiogram, and sometimes in places you can do the WFIM, the functional independence measure, or the PEDI, depending on whatever your therapists are good at. It is really important we maintain participation and environment for these children, including school participation, summer camps. Try to get as much as possible to include them in activities. You need to be aware when you have children with Duchenne muscular dystrophy of two main things. One is you need to avoid succinylsonium anesthetic gases because they can develop malignant hyperthermia. This is not just only for Duchenne, this is for all children with, many of the children with neuromuscular disorders. And avoid excessive and strenuous exercises. That's not good at all. And as you can see, this is a child with a shaft fracture of femur. This is his lungs. When you put them together, this is fat embolus. This can kill the child. This is why always in the clinic, I advise parents that, again, it's mild trauma, and I always tell them about the risk of fat embolus. It's a child which can fall from the wheelchair. Few hours later, they start to have breathing difficulties. It can kill the child if you did not act. So genetic treatments, this is now the future for treatment of Duchenne muscular dystrophy. You have medications like exon skipping. We're doing better than the previous speaker with HD, with antisense oligonucleotides. These medications they have a place in the treatment of children with Duchenne muscular dystrophy. Atalorin is an oral medication that works on nonsense mutation. These three medications above are given as IV infusion. They have a role in treatment. We have currently 2 children on casimersen. One of them is ambulant, and the parents have noticed significant improvement. The other one is non-ambulant. The parents did not see much improvement, but the child feels much better. And there is always future potential for treatment. CAT1004 is a nuclear factor. I have one patient on tamoxifen who started by some physician somewhere in France. I don't know what's the indication, why they went for that, medication. But all these medications, they work on very simple idea, which is to improve muscle regeneration, reduce muscle degeneration, and reduce inflammation. And obviously, there is many gene therapy in process now. Pfizer's have got one. I think there is some other companies doing. And obviously, all these medications, genetic testing, they're going to end up going through the CRISPR-Cas9 technique, which we've learned from bacteria trying to control virus invasions. So this is just briefly and very quickly an overview of Duchenne. I want just to give your attention to these 3 articles that came in the Lancet a few years ago. They are really, really good. They cover almost every aspect of Duchenne muscular dystrophy. Thank you.